I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So similar to breast cancer and colon cancer, we now have bona fide screening modalities that save lives in lung cancer. And it has not come without challenges. So these guidelines originally came out in 2013 based on the National Lung Study, the National Lung Cancer Screening Trial, or the NLST, that was published in the New England Journal of Medicine, that essentially looked at high-risk group of patients defined by age 55 to 80 who had a 30-pack year history of smoking, who are still either smoking or quit within the last 15 years. And that study showed that the patients were randomized in this study to either annual low-dose CT scans up to 3 times versus just observation. And the bottom line is, if you took a high-risk group of patients who didn't have lung cancer yet, who were at high risk of developing lung cancer, and you screened them with a CAT scan to see if you could pick things up early, there was a significant reduction in lung cancer mortality. So screening saves lives, similar to mammography for breast cancer, similar to colonoscopies for colon cancers. We learned from that trial that screening saves lives. And so this is important. This is a message that needs to come not only from medical oncologists, but it needs to come from pulmonologists, but more importantly, primary care physicians who are seeing these patients. And we always try to educate the primary care physicians. Now, we've learned more recently that these guidelines have widened, which is great because the eligible patient population that now can be screened is greater. And so based on newer data, we've learned that the benefit is not just restricted to age 55 to 80, it actually is age 50 to 80. So it gives us another 5 years here age. So patients now are eligible for lung cancer screening if they are age 50 to 80, and rather than 30-pack years, it's 20-pack years. So this lowers sort of the bar in a meaningful way, I think, to capture more patients. Pack years is essentially a shorthand way to say that if a patient has 30-pack year history, that means they've smoked a pack a day for 30 years on average. That's what 30-pack year history means. 20-pack year history means you've smoked an average of a pack a day for 20 years. So this is going to help patients, I believe. As a medical oncologist, unfortunately, I'm on the receiving end of this. So I'm not the one seeing these patients, but I think the medical oncologist the onus is on the medical oncologist and the radiation oncologist to make sure that the pulmonologists and the primary care physicians are doing everything they can to talk to their smoking patients, or even patients who've quit smoking. They're still eligible to advocate for screening. I think we need to remember that the screening message has to be coupled with the idea that roughly 60 to 70% of all lung cancer patients right now present with advanced stage disease, where the goal is only palliation, not cure. And even though those palliative efforts like targeted therapies and immunotherapies, some patients can be cured with those modalities if they have stage 4. We know that there's a better chance for cure in early stage lung cancer. And the only way that we can really start to shift the stages to more early stage is by doing and advocating for CT screening. I will tell you that since CT screening has been implemented, I have been, my practice has shifted a little bit. I'm starting to see more early stage lung cancer, which is great. These are patients, of course, who had a nodule identified on a CAT scan by screening, and the surgeon attended to it, resected it, and then the patient came to me afterwards. So really want to advocate for patients who are high risks, who have a history of smoking, even if they quit 15 years ago. If they're between the ages of 50 and 80, they should talk to their primary care physician or their pulmonologist about getting a CAT scan. It can save lives. We're just at the beginning of this story. We just need to push it out there as best we can so that we can start improving outcomes for our patients with lung cancer.